A warm welcome to Mount Elizabeth Hospital's annual Medical Seminar 2022, jointly organized by Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital. The theme for this year's webinar is Navigating New Hopes and Possibilities. I'm Charmaine E., your host for today. We're very excited to have a lineup of 6 speakers to present on a wide range of topics, and privileged to have Dr. Yong, as well as Dr. Lee Kuo An as our moderators for both session 1 and 2. Each session will have 3 doctors and a 5-minute Q&A that's open to the floor. Before we start today's session, just a couple of reminders on what to do. Below the video stream on the webinar page, there is a Q&A bar where you can submit your questions. Once the question is approved, it will appear under the live questions list. You may then scroll back up to the video stream once you are done. If you have registered with your MCR number, you will be eligible for the CME points by viewing this live session right now. Mount Elizabeth Hospitals will submit your attendance to SMC and SDC for claiming CME points. If you encounter any technical difficulties at all, please feel free to contact us. Our contact details can be found on the bottom left of the website. Our crew is also on standby to help you anytime. At the end of the session, do help us by filling up the feedback form. Your suggestions and feedback will help us improve for future events. Without further ado, let's begin the event with a joint welcome address by Dr. Peter Chow, Chief Executive Officer of Mount Elizabeth Novena Hospital, and Mr. Ming, Chief Executive Officer of Mount Elizabeth Hospital, followed by opening remarks by Dr. John Chia, CME Chairman of Mount Elizabeth Novena Hospital.
Welcome to the 2022 edition of the Mount Elizabeth Annual Medical Seminar, and thank you for joining us. This year's theme of Navigating New Hopes and Possibilities is an apt one, because we have finally entered COVID endemicity, and the healthcare community has adjusted to new norms and patient expectations.
At Mount Elizabeth Hospital, as we celebrate our 43rd birthday this year, there is much anticipation among our doctors and staff as we look forward to Project Renaissance, the multi-year hospital redevelopment project that will commence in January 2023. By 2025, we will have a state-of-the-art and modern tertiary hospital that will meet the new treatment needs of our patients. Our doctors and staff will also have a more conducive and efficient hospital to provide a more comfortable and safer healing environment for our patients.
Yes, and 2022 has also been a very special and significant year for Mount Elizabeth Novena Hospital as we mark our 10th year of service. It is with your support in the past years that we have grown to be one of the most trusted private hospitals in the region by both patients and doctors. But we will keep doing more. One of the exciting new services we will unveil in the next 2 months will be our Proton Therapy Center, which you will be hearing Dr. Lee Kuo An share later this afternoon. When this comes on board, together with our True Beam Linear Accelerator and Gamma Knife Surgery, we will be one of the best equipped hospitals in this region for cancer and neurosurgical management. So even as we enter into our 11th year of service, I value your continued partnership as we continue our mission to give your patients better choices and better chances of returning back to health. Thank you for your trust and partnership.
As Peter mentioned, the legacy of Mount Elizabeth Hospitals is one that was forged from the partnership and support of the doctors, the professionalism of the staff, and the trust bestowed upon us by our patients. We are looking forward to build on the Mount E legacy as we navigate new hopes and possibilities together.
Dear friends, on behalf of the organizing committee, Dr. Richard Fan and I would like to welcome you to this year's annual scientific meeting. As you know, we are living in a world of unprecedented change. Medical technologies are rapidly changing the way that we practice medicine and treat cancer. And all this is driven by scientific advance and new models of understanding disease. Treatments are also getting better, they are getting more precise and less toxic. So the focus of this year's ASM is appropriately on cancer care. With the investment in the new Proton Therapy Center, most of us in the cancer field are filled with excitement on the prospects of improving treatments for our patients. So over the next 2 hours, we hope that to give you a survey on all the exciting developments in the field and bring you up to date, right up to the cutting edge, and maybe a little bit beyond. So thank you for spending the afternoon with us. And over to you, MC.
Now, our first speaker is Dr. Richard Quek, a senior consultant, medical oncologist at Parkway Cancer Center. He's experienced in general medical oncology with subspecialty interests in the management of sarcoma, gastrointestinal stromal tumors, melanoma, and lymphoma. Today, he's going to be sharing more about paradigm shifts in oncology from past to future. Dr. Quek, please. Dr. Quek, lovely to see you again.
Thank you.
Stage is all yours.
All right. Okay, thanks, Charmaine, for the very kind introduction. First and foremost, I'd like to thank the organizing committee, including the two chairpersons, Dr. John Chia and Dr. Richard Fan, for inviting me to give this talk, as well as Mani and the rest of the group. So today I'm tasked with talking about paradigm shifts in oncology from past to future. And without further ado, I'll begin. As a medical oncologist, we are always guilty of presenting too many survival curves. I promise you that in this presentation, I'll limit my survival curves to just essentially a couple of them and just 2 slides. So sit back and relax. And so the overview for today's talk will be a recap of the past treatment strategies, the state-of-art treatment right now, and a bit of gazing into the crystal ball and to predict what the future might hold for patients and all of us. And so I think one of the biggest advance of oncology is the multidisciplinary nature of oncology that's developed over the last decade to 2 decades. And I think we no longer work in silos anymore. We work as a team, and a big team for that matter. And the patient first walks in, and we make a diagnosis through the help of our pathology colleagues. We stage the disease with scans and radiology. And once we know the stage and the diagnosis of the patient, we then huddle to have a pre-treatment discussion amongst the surgeons, the medical oncologists like myself, and the radiation colleagues. And this group treatment strategy has really improved the care, and not to mention the subspecialization that's involved these days. And so as a medical oncologist today, I'll just focus purely on systemic treatment and showcase what are the strategies we had in the past and right now, starting with chemotherapy in the 70s and 80s, and then the high-dose chemotherapy that we use quite a fair bit in blood cancers. In the mid-2000s, we have targeted therapy, and the mid-2010s, immunotherapy. And so this is cytotoxic chemotherapy, and it's got a bad name. Most of us are quite familiar with it, and this works by affecting the rapidly dividing cells because it breaks the DNA. And so the rapidly dividing cells in our body, like hair cells, hair follicles, the intestinal cells, will also get affected. And while there are some side effects, I would say that chemotherapy still forms a big backbone of our treatment in our day-to-day work. Some of the side effects include alopecia, vomiting, neutropenic fever because the marrow cells are involved, mucositis, diarrhea, and fatigue. So if you look at chemotherapy as a bomb, then the next development that came in our sphere was targeted therapy, and that's more like a sniper. And so you need to have a target before you can apply a targeted therapy. And so this is what we typically see in our clinics. A patient walk in with cough, some breathlessness, and an X-ray shows a whiteout of the left lung. But a lot's going on in the left lung. You can see it's whiteout, it's not normal. But the mediastinum is shifted to the opposite side, suggesting a pressure effect. But clearly there's also some gas shadows seen at bronchogram seen in the upper lobe, and also some gas shadows at the bottom. So it's not just an effusion. And if you go into greater detail, you can see a PET scan showing an entire lung whiteout. So if this was in the early 2000s, when I started training, we would say that this patient, we do a biopsy, confirm the lung cancer, and then apply first-line, second-line chemotherapy, and the results are very predictable. First line, 4 to 6 months of disease stabilization response. Second line, maybe 3 to 4 months, and usually patients will do poorly after that. Now, for this patient, we did a PET scan. You can see that the imagery shows a very thick rind of tissue. So it's not in the lung itself, but it's in the pleura. So this thick rind of tissue is causing a lot of symptoms. And in this case, this patient has a lung cancer. It's not a mesothelioma, but it's a lung cancer. Biopsy confirms it. And in this day and age, we do a lot of genetic studies to look at the different types of genetic aberrations the lung cancer may harbor. And most common in our population is EGFR, but the list is now very long. It includes ALK, ROS, BRAF, MET, and so on and so forth. Now, once we find this mutation, then we can apply the targeted therapy, a right target, a right drug to the right patient, could give you a very good response, easily in the 70 to 80% range, depending on which target we're looking at. And that forms the basis of targeted therapy. So for my patient, in this case, we found ALK mutation. Applying the right target, you can see the symptoms improving very quickly and radiological response within a couple of weeks. So this is what we see these days in our clinics with targeted therapy. Now, as the years went by in the mid-2010s, the development of immunotherapy became mainstay of treatment. And as you all know by now, immunotherapy is specific to the immune system. It's not specific to the cancer. It's administered, it raises the immune system, and therefore allows the immune system to kill the cancer from within. And it's approved for use in stage 4 cancers and a broad range of stage 4 cancers for that matter. And I like to use a cartoon to illustrate this point. Again, you see a nasty-looking cancer cell that the immune system is not able to recognize, which is, in this case, the gut dog. It's tightly leashed, it's not able to recognize the cancer, and the cancers then flourish. What happens, we apply a drug, and this drug cuts the leash of the immunity, and therefore the immune system then becomes elevated and goes about doing its job, killing the cancer. And this is what it's all about, immunotherapy. And with the advent of targeted and immunotherapy over the last decade, and I just take one cancer as an example. In this case, I've picked kidney cancer. You can see the development and the paradigm shift in these 3 big jumps. Prior to the mid-2000s, we are using very toxic treatment, high-dose interleukin, given in the ICU setting. Patients have hypotension, they fare poorly, a lot of side effects, and you get poor responses. Then by the mid-2000s, we have targeted therapy, in this case, sunitinib, sorafenib. And then later in the mid-2010s came about immunotherapy. We have a second-line therapy as a single agent, and subsequently in the first-line setting, combination therapy. And the late 2010s, we started to combine immuno plus targeted therapy. And the response is very fantastic. What we used to achieve less than 10% of the time, we get 30% with targeted therapy and 40% with immuno. And in this day and age, when we combine both strategies, we are hitting 60%. And many of these responses are fairly durable. And this is the development I was talking about. Now, switching gears, we talk about melanoma. And stage 4 melanoma, as we all know, is a very deadly disease. And you can see the curve in yellow. 5-year survival, you're going to get a 10%. That 10% of lucky patients, 90% will perish by 5 years. With the development of the first front-runner immunotherapy, which is ipilimumab, anti-CTLA-4, we raised the bar to 20%. Better, but not great. 5-year survival, the median survival is still about 10 to 12 months, so probably about a year or less, so better, but not fantastic. However, in this day and age where we combine immunotherapy, as the patient walks in with stage 4 disease, we can then tell the patient that the median survival now is 6 years, 72 months. So prior times, we would never have imagined that median survival would have exceeded 5 years, but this is what we get routinely these days. So this is what we have in the standard of care treatment, but what about the new approved treatments that we are anticipating? Started this year, anticipating next year, 2 strategies. One is CAR-T, chimeric antigen receptor T-cell therapy, and Proton, which Dr. Lee Kuan will go into greater detail in the second half of the session. I'd like just to touch very briefly on CAR-T because it's an exciting approved treatment that's available now in Singapore. As you can see in this diagram, we have a T-cell. All of us have got T-cells, and T-cells are able to kill viruses, cancers, but in this case, it's not able to recognize the cancerous B-cell, the lymphoma cells. So what's going to happen in this technology is that we're going to take the T-cells out, we're going to manufacture a chimeric antigen receptor into the T-cell so that the T-cells can then recognize the B-cell. It is then given back to the patient, and then this T-cell with its new armamentarium will then go after the cancerous B-cell and thereby killing it. So this technology, we have got a cell therapy. It is a living therapy because the T-cell is alive, it can propagate. It's got targeted therapy modality as well as immunotherapy because it involves the immune cells of the body. And so the process of CAR T therapy, we collect the T cells from the patient, we make the CAR T, manufacture it in an off-site location, we reinfuse the cells to the patient, and then there's a recovery process, and that is fascinating. Now approved for use in leukemia and relapsed lymphoma. Now switching gears is radiation treatment. Again, I mentioned Dr. Lee will go through in greater detail, but I love this slide. It shows a patient here surrounded by a huge machine generating proton hitting the target the way it should. So there's a lot of back-end work and a back-end machinery to support the treatment. And this is my cartoon of proton therapy. This is standard radiation hitting the cancer cells the way it should, but unfortunately these cancer cells continue because it's got energy. It hits the normal cells behind and in front the tumor. And this is where the side effects come in. Imagine proton, this is proton, hits the tumor very nicely and immediately it falls off. And this falling off will then result in the normal tissue before and after the cancer cells being spared. And this is exceptionally good for tumors in critical structures, such as the base of skull, critical parts of the brain, prostate, so on and so forth. So these two technologies are fascinating and they're available. Now, I was tasked to talk about the future of oncology as well, and I'll devote a few slides to this, and I'm supposed to guess what the interest oncology field will shift into. And I think 2 points. Number one is the adjuvant use of immunotherapy. Adjuvant means prevention or preventative use. So far, we have given immunotherapy in a stage 4 setting where patients has relapsed terminal cancer, then we use this treatment. What happens if we use it earlier in stage 3 or stage 2 setting before the cancer relapses? I'm going to show you some slides and I'll bring you through this. And the second area which is of great interest to me is the antibody conjugate. And again, I will go into greater detail. So these are my 2 slides of survival curves. And this is adjuvant immunotherapy, preventative use. We started in melanoma, and this is stage 3 melanoma. Stage 3 melanoma, the relapse rate after surgery is as high as 50–60%. And so what happens, we apply the adjuvant immunotherapy before patients relapse, after resection. And you can see each time you do that, on the blue survival curve, it's at least 10 to 15% better than surgery alone. And we select for stage 3 patients. And more recently, stage 2B and 2C patients also benefit from adjuvant immunotherapy, although not as much, in a range of 6 to 8%. Switching gears, we look at lung cancer. This is adjuvant nivolumab on the left, being applied to lung cancer patients before surgery. You see a response which is 10 times better than chemotherapy alone, and you see a better response, a better event-free survival. And similarly, for stage 3 patients, after chemoradiation, you apply adjuvant immunotherapy, again, you see a survival benefit. And also in kidney cancer, in resected kidney cancer, stage 2, intermediate and high-risk disease, in kidney cancer, post-resection, you see again a event-free, disease-free survival benefit. And this is going to come in the next 4 or 5 years. You can see adjuvant immunotherapy in a broad range of cancers, and we're just waiting for the data to come out. And the last topic I'll talk about is antibody conjugate. And I find this fascinating, and I'm just waiting for more information on this topic. Essentially, again, a cartoon, you can see the cancer cell in orange. It has a target, but unfortunately, the T cells that's patrolling our bodies are not able to recognize the cancer, and therefore it cannot kill the cancer. What happens, we introduce a compound manufactured to detect the target. It's got a red arrow that can detect the target. It's got a little tail at the back. It's called a linker that can link in the T cells, which are the natural immune cells, and it'll gravitate towards the cancer cells, and thereby allowing the T cells to clobber the cancer. And that is what we call a bispecific. You change the molecular structure a little bit, okay, and so you get a targeted portion, you get immunotherapy portion. Change the structure a little bit, change it to a chemo molecule, and you get an antibody drug conjugate. And the combinations are limitless. You can put a few T cells, a few chemotherapy, and then you can send it into the cancer cell. And this is where we anticipate good results. In a way, it's quite similar to CAR T therapy. However, it is not a living treatment because it is a manufactured product, but the good thing is that it's off the shelf, so you don't have a lengthy manufacture process. So in summary, the paradigm has shifted in the management of cancers. Now cancers are treated in a multidisciplinary fashion. The treatment strategies have greatly evolved over the last 2 decades, and the pace of development has also quickened. Now patients live longer and they live better. And so with that, I thank you for your kind attention. hand over to Xiamin.
Thank you very much, Dr. Quek. Looking forward to the panel later on.
Thank you.
All right, we'll see you back on screen in just a bit.
Thank you.
Now, you may submit your questions for Dr. Quek via the Q&A bar below in this video stream. Next up, we have Dr. Xian. Dr. Chan is a cardiologist at both Mount Elizabeth hospitals, Glen Eagles Hospital and Parkway East Hospital. Her clinical expertise includes heart failure and management of patients with mechanical hearts and cardiac imaging, including echocardiography and nuclear cardiography techniques. Today, she will be presenting on the topic Cardio-oncology, risk prediction and surveillance for cardiotoxicity in cancer patients. Let's welcome Dr. Chan.
Hi everybody, I'll be speaking on cardiovascular care in cancer patients, focusing on the risk evaluation and surveillance for cardiotoxicity while the patient receives cancer treatments. Cardio-oncology has gained its importance in the past decade, and the reason is that tumors are actually associated with increased risk of cardiovascular disease. At the same time, with the use of novel life-saving targeted immunologic cancer therapies, there is now being recognized that there is increased cardiovascular off-target toxicities involving heart failure, myocarditis, as well as hypertension. And with improved treatment, there's now an increasing cohort of cancer survivors, and this group of patients require management in terms of their cardiovascular condition. Cancer and cardiovascular diseases are two leading causes of mortality worldwide. In the past, thought of as two separate entities, these two conditions, cancer and cardiovascular disease, actually share many risk factors. At the same time, with emerging evidence, it is found that these two conditions actually has got shared biology and underlying pathogenesis processes involving inflammation, oxidative stress, reactive oxygen species, and underlying metabolic reactions that are linked to both diseases. This is to show that cardiovascular diseases increases incidence of various types of cancer, and conditions such as myocardial infarction and heart failure actually increases various types of cancer. Since it is very common that cardiovascular condition and cancer can coexist in the same patient, it is therefore important that prior to starting cancer therapy, cancer patients should undergo baseline cardiovascular evaluation, looking at evaluating cardiovascular risk factors and assessing for pre-existing underlying cardiovascular condition. At the same time, it is important to understand the tumor type, the tumor biology, and the choice of cancer treatment in this group of patients and the associated cardiotoxicity. Once cardiovascular assessment is done with a baseline risk stratification, we could provide primary and secondary prevention strategies, a structured and personalized surveillance while the patients receive cancer treatment, and long-term survivor surveillance in this group of patients, since many of them would experience cancer therapy-induced cardiotoxicity as well as pre-existing cardiovascular condition. This field of medicine has got limited trials and evidence. However, the last few months, the European Society of Cardiology published a guideline providing guidance on the management of cardiovascular conditions in cancer patients. It is important at the baseline to assess for the baseline cardiovascular risk, looking at patients' cardiovascular risk factors, pre-existing cardiovascular condition, whether the patient has got previous cardiotoxic therapies, and taking into account the cancer therapy treatment that's being used and their associated cardiotoxicity. With that, the approach to cardiovascular risk assessment would further involve further evaluation, including a clinical assessment physical examination, typically involving further evaluation with an ECG, blood tests for biomarkers, and transthoracic echo to assess for the heart function using LVEF as well as subclinical LV dysfunction with GLS or global longitudinal strain. Depending on the cancer therapies and chemotherapy agents being used and their cardiotoxicity involved, different arrangement in terms of cardiovascular assessment with blood tests and transthoracic echo can be arranged. This is the baseline risk assessment templates for anthracycline chemotherapy as well as HER2-targeted chemotherapy from a position statement of the heart failure group of the ESC as well as the International Cardio-oncology Society. Taking into account various risk factors, a risk stratification is performed and a risk level is being designated to the patients. depending on the likelihood of cancer therapy-related cardiotoxicity and the clinical severity that's being involved with the cardiotoxicity. In patients who are high risk or very high risk, it is important to refer to a cardiologist for baseline risk assessment, and discussion could be done between cardiologists and oncologists and involving the specialists that are involved in the care of the patients to decide on the best balance in terms of the cardiovascular risk as well as the cardiotoxic cancer therapy that has to be used. At the same time, in high-risk group of patients, cardioprotective strategies involving use of certain medications like ARB and ACE inhibitor and beta blockers can be employed prior to starting cancer treatment. In low-risk and moderate-risk group of patients can continue routine oncology follow-up with a close monitoring, and if any symptoms and side effects develop in terms of ECG changes or echo changes, cardiology referral can be initiated. Once risk profile is being assessed and stratified, patient can receive primary and secondary prevention strategies. In high-risk group of patients, sometimes may require the adjustment of the dose of cardiotoxic drugs and the regimen. And medications involving cardioprotective agents such as ACE inhibitor, ARB, or beta blockers can be used prior to starting cancer treatment. Once cancer therapy are being started, it is important to provide continuous surveillance for this group of patients who are receiving cancer therapies who may have cardiotoxicities. I'm going to go through several cardiotoxicities that are common in patients who receive cancer therapies. The first one is that of cardiac dysfunction. Cancer therapy-related cardiac dysfunction can be defined looking at LVEF, global longitudinal strain, so a drop in terms of GLS by more than 15% as well as a new rise in biomarkers with a preserved LVEF will be mild toxicity. In severe toxicity, we'll see a drop in terms of LVEF or down to less than 40%. There are two agents that commonly causes cardiac dysfunction, anthracycline as well as HER2 targeted therapies. For anthracycline, chemotherapy agent is commonly used in treatment of solid and hematological cancer. This agent has got dose-dependent cardiotoxicity, and if used with other cancer treatment like Herceptin as well as radiation therapy, there is increase in risk of the cardiotoxicity. Patients receiving anthracycline chemotherapy agents needs to be assessed at baseline, at the same time followed through during their cancer therapy. In high-risk group of patients, ECG, transthoracic echo, and cardiac biomarkers in terms of blood tests will be done at regular intervals to monitor for cardiac dysfunction. Similarly, for HER2 receptors therapies, this group of medication is associated with cardiac dysfunction. It is commonly used in the treatment of breast cancer as well as gastrointestinal cancer. It may lead to LV dysfunction in 15 to 20% in this group of patients. It is important to pick up subclinical cardiac dysfunction early in this group of patients, otherwise progression to overt clinical heart failure will occur. For this group of patients, it is advised that at baseline, ECG, transthoracic echo, and cardiac biomarkers are done for high-risk group of patients. And for patients receiving this medication, it is advised to have transthoracic echo at regular intervals, and for high-risk group, even regular measurements of cardiac biomarkers. For patients who develop cardiac dysfunction while receiving anthracycline, in the severe group, the medication needs to be discontinued. In patients who has moderate cardiac dysfunction, this medication has to be stopped transiently and await the improvement of LV function, and thereafter restart if necessary after a discussion with the multidisciplinary team. In HER2 targeted therapies, for patients who has got moderate to severe cardiotoxicity that develops during cancer treatment, it is important to stop the medication transiently and await improvement in terms of the LV function, at least up to more than 40%, before rediscussion if the chemotherapy agent could be recontinued and restarted. The immune checkpoint inhibitors are increasingly being used in cancer therapy treatment due to its unprecedented cancer treatment effects. However, this group of medication has been associated with various cardiovascular conditions due to its augmented immune response. One of them is immune checkpoint inhibitors myocarditis, incidence being in the range of 0.3 to 1%. It is a severe complication with high mortality rate and usually develops during the first 12 weeks of the treatment. In a large case series, there's up to 50% mortality rate in patients who develop immune checkpoint inhibitors myocarditis. Therefore, in patients receiving immune checkpoint inhibitors, it is important to provide a surveillance protocol for this group of patients. At baseline, they should have baseline cardiovascular assessment, ECG, as well as cardiobiomarkers blood tests. In high-risk group of patients, it is important to do a baseline transthoracic echo and to follow through this group of patients with regular cardiobiomarkers in terms of blood tests. In the event of fulminant myocarditis in patients receiving immune checkpoint inhibitors, the treatment will be high-dose methylprednisolone steroids, and patient needs to be closely monitored in the ICU setting for further deterioration. Hypertension is a common adverse effect in patients receiving VEGF inhibitors as well as proteasome inhibitors. Therefore, in this group of patients, it is important for a baseline cardiovascular assessment, ECG, as well as daily blood pressure monitoring when the patient goes through cancer treatment with these medications. At the same time, with every increase in dose of this treatment, it is important to do regular blood pressure monitoring, and once they are more stable, then at a wider interval of 2 to 3 weeks. The target blood pressure for hypertension in patients receiving cancer treatment is less than 140/90. If patient experiences blood pressure of more than 180 and diastolic more than 110, it's important to actually stop the medication early and allow and start treatment of hypertension. The first line of treatment would be ACE inhibitor and ARB. Once hypertensive treatment is started and blood pressure is controlled down to less than 160/100, the chemotherapy agents can be restarted in patients for cancer treatment. Certain cancer treatment predisposes to acute coronary syndrome by accelerated atherosclerosis process, plaque rupture, vasospasm, as well as coronary thrombosis. In cancer, presentation of acute coronary syndrome can be atypical or masked by cancer as well as therapy-related side effects. This group of patients should receive treatment according to the general cardiology guidelines for STEMI and NSTEMI if the life expectancy is more than or equals to 6 months. Upon completion of cancer therapy, it is important to continue further monitoring surveillance for cardiotoxicity, especially in the first 1 year after completion. As seen in this prospective study, the overall incidence of cancer therapy-related cardiotoxicity is 9%, and up to 98% of cancer could be detected 12 months after completion of therapies, and the median time is that of 3.5 months. In fact, in high-risk patients, it's important that within the first 12 months, regular assessment, including clinical as well as ECG and echo, may be required in patients who are high risk. So which are the cancer survivors who require cardiovascular surveillance in the first 1 year after cancer treatment? These include patients who have high risk and very high risk baseline cardiovascular risk, patient who has received cardiotoxic cancer treatment with a high risk of long-term cardiovascular complication, including high accumulative dose of anthracycline, high dose of radiation therapy, or a combination of anthracycline and radiation therapy used in their cancer treatment, patients who develop moderate or severe cancer therapy-related cardiovascular toxicity during their treatment, including patients with arrhythmia, heart failure, and vascular toxicity, and in any of the patients who during the surveillance process develop new symptoms, new changes on ECG, biomarkers, or transthoracic echo. In patients who develop moderate to severe cardiotoxicity during their cancer therapy treatment, it is actually important to put them through a structured assessment during the first 1 year after the completion. This may include clinical assessment, ECG, transthoracic echo, and cardiac biomarkers at regular time intervals. There's now an increasing cohort of cancer survivors due to improvement in terms of cancer therapy treatment. In all cancer survivors, it is important to monitor them in the long term for cardiovascular risk. Recommendation would be to do an annual cardiovascular risk assessment, and if any symptoms develop or any changes in terms of cardiovascular risk, to dealt with as appropriately. In patients who are high risk, that will include patients who receive cancer therapy, who has got pre-existing cardiovascular condition or cancer therapy-related cardiotoxicity. It is important that they be put through regular surveillance and assessment, which may include use of ECG and transthoracic echo at regular interval. Many of the cancer survivors will experience cancer-related or cancer therapy-related late effects throughout their lives. In some types of cancer, the cardiovascular risk and condition risk actually exceed cancer mortality and reduces the life expectancy and quality of life in this group of patients. Although it's important to reduce cardiotoxicity in patients who receive cancer therapy, however, it's important to remember that cancer therapy is important in patients with cancer for their long-term survival and outcome. The concept of permissive cardiotoxicity, where a balance of benefit or effective cancer therapy with the acceptance of certain degree of cardiotoxicity, so long as the cardiotoxicity is monitored closely and treated optimally, and patients do not have life-threatening cardiotoxicity, to continue the cancer therapy to enable the long-term survival and outcome of cancer patients. This concept has to involve collaborative discussion between specialists treating the cancer patient and involve patient and family in terms of discussion, counseling, and understanding of their treatment process. In conclusion, cardiovascular risk stratification, surveillance for cardiotoxicities, and long-term cardiovascular care are important care components of cancer patients. This area of medicine is gaining importance as we recognize cardiotherapy-related cardiotoxicity in novel therapies that we are using for our cancer patients. There's also a growing number of cancer survivors with improvement in cancer treatment. Although this area of medicine has limited trials and evidence to base decision-making, but there are recent guidelines that have been developed to help provide guidance on a proactive and personalized approach to manage cardiovascular condition in cancer patients. It's important to remember that although reducing cardiotoxicity is important in this group of patients, but cancer therapies are life-saving and continuation are actually important for long-term survival and oncologic outcome. The concept of permissive cardiotoxicity should be considered to balance effective cancer treatment with acceptance of certain degree of cardiotoxicity while we provide surveillance and early treatment for cardiovascular consequences. The objective is to allow this group of patients with cancer to remain on the best possible cancer treatment to improve overall survival and outcome while minimizing cancer therapy-related cardiotoxicity. With that, thank you for listening.
Thank you so much, Dr. Chan. Now you may also submit your questions for Dr. Chan via the Q&A bar below the video stream. Our next speaker is Dr. Jason Yap, a family physician. Dr. Yap is the anchor doctor at Parkway Shenton Medical Group Clinic in the Arcade at Raffles Place and holds the appointment as clinical lead for Parkway Shenton Primary Care Network that oversees team-based care of patients with chronic medical conditions from 36 clinics within the organization. Today, he'll be sharing about his experience on cancer detection, the role of primary care physician. Dr. Yap, please.
Good afternoon. I'm so happy to be here with you. Thanks for the invitation. As we all know, Healthier SG will be rolled out next year. And a very large part of Healthier SG is on preventive care. In fact, the whole healthcare transformation will be focused on preventive care. And in preventive care, cancer detection plays a very important part of what a primary care doctor should be doing in his primary care practice. I have asked two of my colleagues in the executive health screeners to share with me some of the cancer detection that they had over the past couple of months. And indeed, I was very pleasantly surprised how many cancers they have picked up. For instance, this 73-year-old Indonesian gentleman who presented with enlarged prostate where it was nodular and a PSA test was done and it confirmed cancer. And another one, the 39-year-old married lady who presented with rectal bleeding for 2 months. And indeed, just by doing a simple per-rectal examination, a hard friable mass was detected and later on found to have cancer from colonoscopy. And 45-year-old married woman who came for routine health screen and mammogram was done and indeed breast cancer was just detected without any difficulty. Another one, 35-year-old lady who had left breast lump. And again, for this particular lady, ultrasound was done because she's less than 40, and taller than wider images was present, and that picked up cancer stage 1 of the breast. And 52-year-old gentleman, left thyroid nodule, and ultrasound was done, and that also picked up a cancer. Another one, this is interesting, hyperacusis of the right ear. And the colleague of mine was very sharp in the acumen and immediately ordered rhinoscopy, and CT scan of the head showed early stage MPC. And 40-year-old lady who presented with abdominal bloatedness and secondary amenorrhea, and ultrasound picked up ovarian cancer. And another one who had persistent watery vaginal discharge, and a team prep picked up cancer of the cervix. And finally, gastroclear. This is something that some may want to consider doing because the patient may not be keen to do a gastroscopy, and gastroclear, when it shows intermediate or high risk results, and scope then can be arranged. It is also helpful for us to know when we want to consider cancer screening, where are the evidences. So Screening Test Review Committee report in 2019 had come up with outlines where appropriate screening tests based on scientific evidence and risk profile of the individual can be used in order for us to consider the different types of screening. For instance, Category 1 is suitable for population-level screening, where there is robust evidence and is clinically effective and cost-effective. For instance, pap smear to screen for cervical cancer and a FIT test for colorectal cancer. And Category 2, where this is suitable for individual level decision, where it is not for the entire population, but it's only for the high-risk population. What is Category 2? For instance, just for an illustration, kidney function that is useful for screening for impairment of the kidney function in persons with diabetes, not for screening of the entire population. Or, for instance, those who have hepatitis B and ultrasound of the liver is considered as a screening that is suitable for individual level decision. Category 3, this is not recommended. There is insufficient evidence, it is not effective, and there's net harm that outweighs the benefits. And this is in the schematic form where we can easily see which of the screening cancer belong to which category. Category 1, you have pap smear, mammogram, or cord blood for stool tests, and these are all effective and cost-effective for general population. And Category 2, this is useful for high-risk population. Example, those who have hepatitis B and ultrasound of the liver is considered a good test for such high-risk individual. And Category 3, there's insufficient evidence on its usefulness, and pelvic ultrasound is one. And another one is a tumor marker like CA125, where net harm outweighs the benefits. Why? Because some of these individuals who have raised CA125 may be because of menstruation or cysts in the ovary or even fibroid in the uterus. Then we need to also consider how old is too old for cancer screening. For instance, if the 10-year life expectancy is not, for instance, 7 to 9 years benefit from screening, and you cannot see beyond 10 years, then this screening will not be suitable for this particular individual. And if this individual is not prepared to go for any treatment, there's no point in doing an elaborate cancer screening. And the other aspect that we need to consider is the age of the so-called incidence, where like for ovarian cancer, where it's higher in older women, which is above 50, so you would not want to do that test for a woman who is 40. So another way to present this, for average risk, colorectal cancer, 50 and above. Yeah? fecal immunochemical test is considered a very helpful and effective test, which is done every year. And for colonoscopy, if it's indicated, it's done every 5 to 10 years. And for breast, in the women between 50 to 69, mammogram is done every 2 years. And for those who are between 40 to 49, mammogram can be considered where the benefits outweigh the harm. And this can be considered on a yearly basis because women in this age group in Singapore have a higher breast density, and therefore it should be done on a yearly basis. And cervical cancer for women aged 25 to 29, pap smear is considered a very good and effective test. And for those who are sexually active, it should be done every 3 years. And for women who are aged 30 and above, a HPV DNA test is recommended, and this can be done every 5 years. And for colorectal cancer by colonoscopy, yes, it should be considered for those who are 50 and above, and this can be repeated every 5 to 10 years, depending what was found. And for those who are intermediate risk, for instance, those who have first degree relative who have cancer, and these individuals can have colonoscopy that is 10 years, within 10 years of the age of the diagnosis of the youngest member of the family who had cancer of the colon. And this can be repeated every 5 years. And personal history of colorectal polyps, so depending on the type of polyps, if it's hyperplastic, it can be done or repeated after 5 years. If it's an adenoma, it should be repeated after 3 years. And these are high-risk group for women who have genetic risk, BRCA carriers, and mammogram and MRI breast can be considered for these individuals and starting from age 25 to 30. And for those who have chronic hepatitis B and the gastroscopy, or rather, I beg your pardon, alpha-fetoprotein is recommended together with ultrasound of the hepatobiliary system, and this is done every 6 months. And for those who have problem with, say, individuals who smoke cigarettes of more than 30 pack years and are continuing to smoke or had quit less than 15 years ago, a low-dose CT scan can be considered every year. And for the men, those who are aged 50 to 70 with life expectancy of more than 10 years, they can consider a prostate-specific antigen test. And at this juncture, I'd like to suggest that besides doing cancer screening tests, we should also check with our patients whether they drink alcohol or not, especially for women, because alcohol is classified as a Group 1 human carcinogen by the International Agency for Research, and is considered to be toxic for our body. And alcohol is known to cause DNA damage in the cells, resulting in the increased estrogen levels and may lead to obesity. 118 studies have concluded that any amount of alcohol increases a woman's risk of breast cancer, and regular drinkers more at risk. And compared to women who does not drink any alcohol, a woman who takes 3 drinks per week has 15% increased risk. This risk goes up by 10% for each additional drink she has on a regular basis. And 1 in 4 breast cancer cases is attributable to alcohol usage, and this occurs in women who drinks 1 bottle of beer or 2 small glasses of wine on a daily basis. And the other thing that we need to look at for women who want to check for cervical cancer, and this is considered a Category 1 screening, and is recommended for all women who are sexually active. And they should start screening at the age of 25, and for 25 to 30, it is a pap smear, which is done every 3 years. And for those who are above 30, then they will consider HPV testing. And for fecal for occult blood, and this it will be helpful to pick up colorectal cancer, recommended for average risk individuals. And this is started on from 50 years and above. and an average risk person who is asymptomatic, individuals who are 50 and above should begin doing this stool for occult blood test. And colonoscopy, this is one of the recommended screening tests for the average test risk asymptomatic population from age 50 and above. And the other thing that we should also take note besides cancer screening is to check on the patients that we see regard to their body mass index. If they are obese, this is considered a risk factor for colorectal cancer and increases the risk by 1.5 to 2.8 folds, especially for those who have abdominal obesity. The other thing that we should also remember to check with our patient is on smoking, because smoking would also increase cancer risk. For instance, smokers who smoke more than 20 pack years have an increased risk from 2 to 3-fold. 30% increased risk of colorectal cancer, 50% increased risk of dying from colorectal cancer, and the risk persists 20 years after quitting. This is a good way to summarize, and for those who are familiar with Screen for Life, for Singaporeans, for those who are aged 25 and above, cervical cancer screen can begin, and for those who are above 40, they can also add on chronic disease screening like cholesterol, blood sugar, in addition to cervical cancer. And for those who are 50 and above, they can add on a colorectal screen like stool for occult blood, and also for colonoscopy, and or add on the chronic disease and the cervical cancer besides breast mammogram. And these are just charges that you can see that from Screen for Life, for Pioneer Generation, they don't need to pay a single cent. For Medicare, and for those who are holding the CHARS orange and blue card, is $2, and for the rest is only $5. I come to the end of my presentation. I'd like to just share with you how I benefited from the understanding of what it means to square off the curve of my patient. Now, most of us would remember the word aerobics. It was termed by Dr. Kenneth Cooper in the 70s. He also coined a phrase, squaring off the curve, which I benefited a lot. And what does that mean? Most of us think that when we reach 40 years of age, we actually might end up with high blood pressure, with diabetes, with heart disease, and then we end up being bedridden, and we kind of go that way. But Kenneth Cooper says that we can actually square off our curve. At the end, we can live to the last days of our life without having any chronic conditions. And how do we do that? We delay the onset of diseases, we picked up cancer early, and we compress our morbidity so that we can continue to live till the last days of our life. And there's a video clip that I'd like us to watch, and we shall learn something from him. It's just less than 2 minutes.
A little bit faster, 3.6 miles an hour. I could never predict what I'd be doing at the present time, all over the world. And to be 87 years of age, never thought I'd get this old. My father died at 77. I'd already outlived him by 10 years. Now I'm going to go through some exercise on the equipment. The whole world's opening up to us because we're proving that preventive medicine's here to stay. 18, 19, 20. Now keep in mind, when I was in medical school back in the 50s, we were taught that preventive medicine was a Cinderella of the medical specialists because there's no profit in health. The profit's in disease. Look at this fantastic races we have here now. And I'm happy to say it's all paid for. Chuck, good to see you.
Good to see you again. How are you?
21st century medicine is at least proper weight, proper nutrition, and proper exercise. You have to combine all of them. You just can't just concentrate just on one, if you want to control your weight. But remember, your health is your responsibility. It's not the responsibility of the government, the insurance company, or physician. It's what you do for yourself. How long you live and how well you live, and hopefully square off the curve, that's my goal, live a long, healthy life to the fullest, and then die steadily. My life will be complete. The first step in getting fit is to avoid inactivity. Just try walking, collective or sustained, at least 30 minutes most days per week. They can increase the life expectancy by at least 6 years and reduce deaths from all causes by 58%. As you get older, you need to incorporate more weight training. During your youth, you have good muscle mass up to about 50 years of age. If you don't do something after 50 years of age, you're going to lose muscle mass. Let's do something along with that. 29 and 30. That concludes my workout.
Thank you for watching. I'm sure we have learned something from this video clip, and this is an important reminder for us how important is a healthy lifestyle, and what we need to do for us primary care doctors. Our role really is to help our patient, and especially so for every patient that comes to my consult room, I ask myself one question: can I help square off this person's curve? And I would spend a bit of time to consider cancer screening as something that will help my patient square off the curve. On that note, thank you very much.
Thank you so much, Dr. Yap, for your insightful talk. Now we've got our speakers that are getting ready for the panel discussion right now. Continue to put your questions in via the Q&A function at the bottom of your screen. Now for referrals for your patients to see Mount Elizabeth Hospital's specialists within 1 day, do use this hotline or WhatsApp. We've now come to the live Q&A of the first session. At this point, we'd like to invite Dr. Yong, medical oncologist, as well as Dr. Lee Kuo-an, radiation oncologist, to moderate our Q&A session with our speakers from the very first session, Dr. Quek, Dr. Chan, and Dr. Yap. Over to you, Dr. Lim, Dr. Lee. Stage is all yours.
Thank you very much. Maybe I'll ask the first question to Dr. Chan. Which patient do you think should be started on some kind of prevention, like ACE inhibitors, ARB, or beta blockers for primary prevention of cancer therapy related to cardiac dysfunction prior to starting cancer treatment?
Yeah, so I think in the talk I mentioned, when we do a baseline, when we see the patient, it's important to do a baseline cardiovascular risk assessment. So as per what I've gone through, there are quite a few things that the guidelines, the recent ESC guidelines has recommended. So once we assess the risk, we know which risk profile they belong to. So in the high and very high risk group, so in this group of patients prior to starting chemotherapy medications that can put them at risk of cardiovascular or LV dysfunction, then we do need to consider starting them on ACE inhibitor or ARB and beta blockers. Yeah.
So I have a question for Dr. Quek. In this era of targeted therapy where the drugs are so specific, and you can get fantastic responses with not much side effects, you can never quite fully predict it. But if you do find a drug target when you do your next generation sequencing, I understand from this year, many of these drugs will no longer be approved for payment because they may not have been tested in that specific cancer, even though we know that in your particular patient, they do harbor a mutation that makes that drug a potential predictive drug. Yeah. How would you get around this problem, or what do you think can be done?
So this is a very tough question and a very good one, Guan. I see it as two components. The first component will be what is already well recognized within the cancer itself. So you do the mutation testing to allow for first-line treatment. And many of these first-line treatment, as you have mentioned, are approved locally and within the cancer drug list and are indicated for use and is reimbursable by insurance. There's another group which is usually more later lines of treatment. These are the more end-of-the-road patients whom we are trying to find a novel, less predictable target for which there may be a drug available, a commercially available drug. And for this group of patients, they may be affected because it is not approved for use in the indication, not approved for use on the CDL. And for this group, we seriously and need to wait for the advisory coming out from the insurance industry by the end of this year. There will be some changes to our insurance coverage in terms of riders, in terms of what's covered and what's not covered, and we await more news. We hope that the news will be positive for all of us and all our patients.
Thanks.
Okay, maybe I'll follow on with the question to Dr. Quek. So in this day and age, with new technology, what do you do in your practice? Do you check everyone with liquid biopsy, whole genome sequencing for everyone that first presents to you, or do you do it after the first line, treatment?
Okay.
Yeah, when do you do it, and how often would you repeat it?
Okay, so good question, Yong. Thanks for that. So in essence, my practice mirrors the guidelines very closely. So if you have some of the common cancers, which including lung, breast, colon, for example, and there's a standard panel which we will typically do. So the breast will include ER, PR, HER2 status. The colon will include KRAS mutation in a metastatic setting, BRAF, even NTRK. So there's a fixed panel, and these are meant, at least for the colorectal cancer patients, meant for stage 4. Similarly, for lung, there's a panel of testing that allows us to initiate first-line therapy. Now, some of us do liquid biopsy, and it's actually advised in some of the guidelines to be performed at time of progression. So a liquid biopsy essentially is a blood draw to look at changes in the cancer mutational profile that has evolved with the advent of drug therapy. So it's under drug pressure, things change, and you're looking for what the changes are. And in many cancers, this is advised, in particular lung cancer, to look for secondary mutation. Do we practice that? Yes, of course we practice that. Now, to link it up with Guan's question is, can we change therapy after we find these mutations? So that one remains to be seen, what is going to be covered, what's not going to be covered, and certainly we want to watch that space closely.
I have a question for Dr. Yap. I've always found it a bit puzzling that as people get older, the incidence in the age group of cancer rises. And yet for the screening recommendations, once you pass a certain age group, the recommendation becomes to stop screening. Sounds a bit like a paradox. Is that any way to get a head around how to understand why once you pass a certain age group, the recommendation is to stop screening?
I guess this is based on research and also on the cases that have been collected so far. It appears that for it to be cost effective, we are talking about category 1 cancer screening, then there is a need to find out which age group is the best time for cancer screening to be recommended. So for instance, like we take age 40 as a cutoff. For those who want to ensure that they do not have problem with the breast cancer, you want to begin from the age. And for those who are 50 and above, colorectal screening is important because based on studies, it is much higher above the age group. The same goes for the other cancer, like even the cervical cancer, for those who are sexually active above the age of 25.
Are any of these covered by, or does patient have to pay for it by themselves, or is there any government subsidy?
Yeah, I think in my talk I did mention about Screen for Life. So for those who are 50 and above, colorectal cancer screening, the FIT test is provided for. And for those who are female, who are 25 and above, they can do pap smear. And if they are above 30, they can do DNA screening. And there's a HPV DNA screening. And they only need to pay $5, which is very affordable for Singaporeans.
Thank you.
Maybe I'd like to ask Dr. Chan a question from the role of primary care physician. I understand from your talk that the risk of cardiovascular events is much higher for cancer survivors. So maybe you can advise primary care physician, what should we be looking out for when they come to see us?
Yeah. So I think now we are more aware, and the population of cancer survivor is actually increasing with proper treatment and more and more people surviving from their cancer. So most times when patient goes through treatment, chemotherapy treatment, there are side effects that we have mentioned about that's associated. So I think what's important is that when past the completion, within the 1 year actually past the completion, we are actually more on higher alert in that sense. There's certain screening protocol that I've gone through in my talk. But beyond that as well, lifelong, actually a lot of these patients have got significant cardiovascular risk. So not much difference from the usual cardiovascular guidelines is that we screen for cardiovascular risk factors, diabetes, hypertension, hyperlipidemia. Weight is an important issue as well in that sense, as we have spoken about in my talk. And also the important part, I guess, in this group of patients is that it is good to have some understanding, although sometimes not always easy, of what kind of treatment that they have received in terms of chemotherapy treatment, radiation therapy, because with different treatments comes certain side effects with the treatment. So it's good, I think, for all of us in healthcare to have some sense of that. So not always possible, but if there's a chance of knowing what kind of treatment they've gone through, and more importantly, if they have sustained cancer therapy related cardiotoxicities, then take it from there, be a bit higher risk. And important thing, I guess, is as general, we do an ECG. And then if there's any new symptoms clinically, then we have a low threshold at referring to a cardiologist for further evaluation.
Okay, thank you. Okay, we have one last question. I would like to ask Dr. Yap as well. It's very exciting to see that you're trying to do a lot of cancer prevention, obesity, smoking, alcohol, even getting your patient to kind of enroll on a exercise program. Can I ask you, in real life, how do you approach it? Let's say, they usually come together. An obese patient who smokes heavily, drink heavily. How do you approach it, and how successful are you in doing this cancer prevention counseling?
I found that the statement, how to square off the curve of a patient, very helpful for me. So for every patient that comes to my practice, I ask myself, can I square off this person's curve? In other words, can I delay the onset of diseases, whether it's chronic diseases or cancer, as long as possible, so that upon detection, you'll be towards the end of their life, so that we actually compress morbidity. So in other words, we actually help patients to live healthily as long as possible. So when patients come to see me, I would check their blood pressure, I would check their weight to make sure that they are within the healthy range. If they are not, then I would share with them the importance of maintaining a healthy weight. And I would advise them, just by cutting down 5% of their weight, if they are overweight, will be translated to a lot of health benefits. And sometimes I would share my personal example, how I squeeze out just 7 minutes, the scientific 7-minute workout. And that is something that's doable, which I do before I take my shower, after I come back from work. And I find that very helpful. Yeah.
Okay.
Yeah.
Yeah. So I think we've come to the end of this segment. So we'll pass it back to MC.
Thank you very much, doctors. A very engaging webinar indeed. And a big thank you to our speakers from the very first session, Dr. Quek, Dr. Chan, and Dr. Yap, as well as our moderators, Dr. Lim and Dr. Lee. Do stay on the webinar with us as we get ready for the second session of our webinar with more medical insights from our medical specialists. We'll see you soon.
Mount Elizabeth Novena will be the first private hospital in this part of the world to have a proton beam therapy center. Proton beam therapy is relatively new, and there isn't a facility like this in this part of the world. The equipment has arrived from Belgium, pretty smooth. We had specialist contractors and project managers helping us.
From the early days where multiple teams came together to evaluate the project, feasibility was no easy feat.
Project went on well until, of course, COVID hit, and I think that has really been our biggest problem to date.
The patient is a 66-year-old Chinese national and a resident of Wuhan.
Any construction project would have its fair share of challenges over the pandemic period. And I salute everybody from our corporate teams, our hospital teams, even our partners, the construction teams, the workers on the ground, all doing their best, all giving up everything that they have, making personal sacrifices to ensure that this project comes to fruition. This Proton Therapy Center is easily one of the heaviest and most complex investment undertaken by IHH Healthcare Singapore in recent years, because we wanted to provide another option of possibility for our patients. This whole spirit of devotion, dedication is a hallmark of the entire center.
With this center, we will now have a full suite of services for our cancer patients, namely chemotherapy, radiation therapy, and surgery. Our patients who come to us in Singapore and from this region will find that they will have comprehensive services, and we hope to extend this not only to patients in Singapore but also to all our patients who come to us from the region.
Hey, thank you so much for staying on the webinar with us today, and we know you'll definitely have some questions for our medical specialists during this webinar. Below the video stream on the webinar page, there is a Q&A bar. That's where you can submit your questions. Once the question is approved, it will then appear under the live questions list. You may then scroll back up to the video stream once you are done. Hey, without further ado, let's kickstart the second session for today. Please join me in welcoming Dr. Benjamin Yip, a gastroenterologist and hepatologist at Mount Elizabeth Hospital. Prior to his private practice, Dr. Yip served in the public sector for almost 2 decades. In Ng Teng Fong General Hospital, he was the only specialist doing both ERCP and EUS. His topic for today is advanced endoscopic techniques in the management of gastrointestinal malignancies. Dr. Yip, please.
Good afternoon, ladies and gentlemen. I am Dr. Benjamin Yip, a gastroenterologist with subspecialty interest in advanced endoscopy, and I thank the organizers for giving me the opportunity to give a talk this afternoon entitled Advanced Endoscopic Techniques in the Management of GI Malignancies. This is my talk outline. First, I'll define what advanced endoscopy is. Then I'll give a list of advanced endoscopy procedures that are performed commonly in GI malignancies, and then I'll home in on pancreatic ductal adenoCA or PDAC, and I'll touch briefly on cholangioCA, which I don't have much time for, and then I'll give some concluding remarks. So first up, some definitions. So advanced endoscopy is divided into major and minor skills. For the major skills, we have EUS, or endoscopic ultrasound. We have ERCP, or endoscopic retrograde cholangiopancreatography. We have ESD, or endoscopic submucosal dissection, so on and so forth. There are also minor skills, including radiofrequency ablation, or RFA, or endoscopic placement of intragastric balloons for weight loss, so on and so forth. What are the list of procedures that one can do in GI malignancies endoscopically? Typically, we divide the gut into luminal structures from the esophagus down to the colorectum, and then the solid organs. So likewise, for advanced endoscopic procedures in malignancy, you can divide out in the same way. As you can see, for the luminal structures, self-expandable metal stents, or SEMs, is commonly used, and the early cancers can be treated with ESD. For the pancreatic cancers, ERCP and its various diagnostic and treatment techniques come into fore, and endoscopic ultrasound, or EUS, again with its various diagnostic and therapeutic maneuvers are also important. And I've started the the EUS therapeutic techniques, which try to access the bile ducts when standard ERCP has failed, and also for patients with gastric outlet obstruction, endoscopic gastric bypass can be undertaken via EUS. For the biliary cancers, similar ERCP and EUS techniques can be done as well. So I'll not be touching on the luminal side of things today. I'll be focusing mainly on PDAC. Okay, some pictures here. To the left, you have self-expandable metal stent, or SEMs, and these need to be anchored down with a endoscopic stitching device in the center, or over the scope clip on the right side. The picture on the left shows ESD being done on the early gastric cancer. This is in the distal antrum and performed using a needle knife. The cartoon on the right shows ERCP. As the name suggests, it is an endoscopic technique to access the bile duct or pancreatic duct. The pictures on the left shows various biliary stents. The top two on the left are plastic stents, and they come in straight or pigtail varieties. And the next two pictures shows biliary SEMs, or expandable metal stents. So the pictures on the right shows the cholangioscopy device from Boston Scientific, which is single operator performed nowadays. The two pictures here depict the EUS, in particular the linear type echo endoscope. As you can see, this is a fine needle being inserted down the scope channel, and it can be seen real time on ultrasound. Now moving to PDAC proper. How does one diagnose PDAC? I think it's best done using ultrasound via EUS, and FNAB is widely done nowadays and is the best mode for obtaining tissue, even if the tumor is poorly visualized by other imaging techniques. And it's shown to cause intraperitoneal spread less commonly compared to percutaneous biopsy. As you can see here, it's very high in sensitivity and specificity. So the picture on the right shows a head of pancreas tumor that is abutting the portal vein, and this can be sampled readily on EUS. What about comparing EUS with CT in diagnosing and staging pancreatic cancer? It is found to be better compared to CT, and EUS gives a better T staging, whereas the X staging is the same as CT. So this is it in the table form. As you can see, across all variables, EUS tends to perform slightly better than CT scan. Except when the mass is quite big, then both modalities can pick up the tumor. What about vascular invasion? EUS tends to do quite well as well, and its sensitivity reaching 100%. And with an odds ratio, it's very good of more than 40. And what's the accuracy of actually EUS FNAB from a meta-analysis that was done of over 1,800 patients? The overall sensitivity and specificity is very good, more than 90%. Okay, I will skip this. And the AURC is excellent as well, 0.974, with an excellent odds ratio of 168. What about EUS FNAB compared to percutaneous biopsy? In a prospective randomized trial comparing both these approaches, there was no difference found, but EUS FNA was found to be more useful when the lesions were smaller. So this is the said paper. Although numerically EUS was better with a sensitivity more than that of ultrasound and CT, but unfortunately it was not statistically significant because actually the trial failed to reach its enrollment targets. What about advantages over EUS versus percutaneous? As mentioned before, there's less risk of needle tract seeding and peritoneal carcinomatosis, and also the cost is reduced. In this retrospective review of 46 patients on each side, only 2% had peritoneal seeding when one does EUS, compared to more than 16% when it's done percutaneously. Okay, next, moving on to biliary stents. So biliary stents can provide minimally invasive and effective palliation of jaundice. Randomized trials and meta-analysis have showed no difference in survival between endoscopic stent placement and surgical bypass, but endoscopic stent insertions have got lower morbidity and mortality. So this is a systematic review comparing endoscopic and surgical bypass. Of course, in terms of recurrent biliary obstruction, it favors surgery. But when you compare metal and plastic stents, then it favors metal stent. And the lowest graph would show two types of commonly used materials for the plastic stents, and there is no difference in terms of biliary obstruction. What about indications for biliary stents? There are two main categories, the palliative drainage and the pre-op drainage, and I'll leave you to read the sub-indications. What about the big question, plastic versus metal stents? Now, compared with plastic stents, metal stents have a lower risk of recurrent obstruction, but not superior in terms of technical success, therapeutic success, mortality, and even complications. So many experts have actually advised us to choose these stents based on expected length of survival, quality of life, cost, and of course, physician expertise. So we know that plastic stents have a shorter median patency compared to metal stents, but they also cost more than 10 times cheaper compared to metal stents. in this review by several advanced endoscopy experts, they have suggested that if the patient's survival is going to be more than 6 months, then a metal stent is preferable, or if you have certain problems like impending duodenal obstruction, non-compliant patient who won't come for repeat ERCP, or there was already repeat plastic stent occlusion, or those living very far away, then you can move straight to a metal stent even if the life expectancy is less than 6 months. However, if you have a short life expectancy, then one may go for just a plastic biliary stent. Now, biliary metal stents, there are two types, the covered versus uncovered. Uncovered stents is basically a bare meshwork of wire, and a fully or partially covered stents are those which there is a covering which extends either partially or fully. So the picture on the left shows a bare metal stent, and the picture on the right you can barely make out the covering, and that is a covered metal stent. So what's the difference and advantages? For the uncovered SAMs, it can be placed anywhere in the biliary tree because it doesn't block the cystic duct in a patient with an intact gallbladder, and it has got low rates of stent migration because tissue ingrowth can be expected. For the covered SAMs, the advantages, it is potentially removable because there is hardly any tissue ingrowth. What about disadvantages of uncovered SAMs? You cannot remove it once you place it for more than a month or so, and there are probably higher rates of tumor ingrowth because the mesh metal is open. Covered SAMs wise, the disadvantages that would be there is increased stent migration 6 to 8%, and a patient with intact gallbladder, if you cross the cystic duct, there'll be chance of cholecystitis. So in this study, where they looked at both covered and uncovered stents, they found to be no difference in the stent patencies actually. What about if you compare two types of different plastic stents, a NITI-D by Tae-Wong and a wall stent by Boston Scientific? Again, there are no significant differences in terms of obstruction, but in a subgroup analysis for this paper, they found that for hilar obstructions, the more conformable NITI stents might do better. What about stents inserted by the radiologist percutaneously? I think the evidence is that endoscopic stenting is preferable, as in it has got lower adverse event rates, except when, of course, endoscopic stent placement fails, usually because there's duodenal obstruction or there's prior surgical bypass, making the ampulla not readily accessible by the endoscopist. Now, comparing adverse events between endoscopic and percutaneously inserted stents in this very large database study of more than 7,000 patients having ERCP and more than 1,000 patients having a PTC. So actually, ERCP performs well across the various indicators for both pancreatic cancer and colorectal cancer, and PTC only performs better in a high volume center for cholangiocarcinoma. Performs the same as ERCP. So what about for palliation and pain relief? So one can ablate or neuralize the celiac plexus via EUS, and this is done by destroying the afferent neural pathways and the sympathetic structures, and it's achieved by injecting a mixture of alcohol and local anesthetic. So the cartoon on the lower left shows EUS in the proximal stomach, and the celiac plexus is accessed at the celiac takeoff, and the middle picture shows the celiac takeoff from the abdominal aorta, and the celiac plexus is usually found on either side. And the last picture shows injection of the said materials. The efficacy is proven in this meta-analysis that CPN is good at relieving cancer pain in 50 to 80% of patients and lasts for 2 to 3 months. And this is a study this is a meta-analysis that looked at 3 papers for pancreatic cancer patients, and the efficacy is about 72.5%. Okay, how about accessing the bile duct when standard ERCP has failed? So one can access the bile duct from the duodenum, that is choledochoduodenostomy. One can access the bile duct from the proximal stomach, and that is hepatogastrostomy. And one can also do a rendezvous procedure in the next picture on the left, where the bile duct is punctured and a guide wire is put down into the duodenum, and then the echo endoscope is exchanged for a duodenoscope or ERCP scope, and then a standard ERCP can be done. The cartoon on the right shows a combination of the three procedures. Sometimes when a tumor is small, EUS also can be used to insert fiducial markers to aid the radiotherapists in finding the tumor for RT. Also, for patients with malignant gastric outlet obstruction and not suitable for surgery or not willing to go for surgery, then EUS-guided gastric bypass is coming to the fore with the advent of these new lumen opposing metal stents or lamps. So I'd like to illustrate a case recently that I had. Madam SL, a 72-year-old lady. She's quite frail after a stroke, and she came with painless jaundice, and the bilirubin was 378. So the CT scan clearly shows a head of pancreas mass, and the surgeons have deemed her not to be a surgical candidate. But the patient and the family were willing to consider palliative chemotherapy. So ERCP was done to relieve the jaundice and also to try and obtain tissue diagnosis. So the picture on the left shows the ampulla endoscopically, and I was trying to cannulate the bile duct. So sometimes you get into the duct you don't want to. So I got into the pancreatic duct first, which crosses the spine, and then with a double guide wire technique, the second wire could then go up the bile duct. And then I did a small sphincterotomy on the left here, you can see. And then on the picture on the lower left, you can see a biliary brush inserted into the bile duct, and endoscopic biliary brushings were taken from the stricture. And then finally, I placed a plastic stent because tissue diagnosis is yet to be achieved. Okay, and then thankfully, the biliary brushings yielded the diagnosis, and then the bilirubin came down very quickly, and the patient was referred successively to Med-Onc. So I won't dwell too much about the CCA. I'll just move on to the last slide where it is interesting. You can see some pictures because of time. Okay, so for this interesting study, the Korean authors have studied 111 patients with bile duct tumors, both benign and malignant. There are some pictures that I think are quite nice. So picture on the top left is a nodular mass. On the top right is a smooth, narrow tapering. And the bottom left is a papillary mucosal projection. And the bottom right is actually just a villous mucosal projection. Okay, more pictures on the top left, actually a coral reef-like mucosal mass, and the bottom left actually just shows a messy sort of intraluminal mass. The top right shows a polypoidal mucosal mass, and the bottom right shows actually a small polypoid lesions. And with direct visualized biopsies, all these turn out to be CCA or cholangiocarcinoma. Okay, I won't go through this as well. So in conclusion, ladies and gentlemen, AE is a subspecialty of gastroenterology, and there are various techniques that can be used to manage cancers along the GI tract. And this is best demonstrated with pancreatic adenocarcinoma. As shown, EUS-FNAB is the best diagnostic tool, and both jaundice and cholangitis can be treated or palliated with ERCP and stent insertions, and various newer EUS-guided techniques can offer a variety of palliative options. For cholangiocarcinoma, the same can be done with ERCP, EUS, and FNAB, and also cholangioscopy, and you have seen some nice pictures. And the treatment and palliation procedures and options are the same compared to PDAC. And I thank you very much for your kind attention.
Thank you so much, Dr. Yip. And again, you may submit your questions for Dr. Yip via the Q&A bar below the video stream. Coming up in our next presentation, we have Dr. Tan Ye Hong, a urologist practicing at Mount Elizabeth Hospital. Dr. Tan has a special interest in minimally invasive surgery in the treatment of urological cancers and performs various advanced laparoscopic and robotic procedures. Today, Dr. Tan's topic will be on robotic surgery in cancer, evolution or revolution. Dr. Tan, please. Dr. Tan,
Hello.
Stage is all yours.
Thank you. Good afternoon, ladies and gentlemen. I thank the organizer for inviting me to share the experience of robotic surgeries in cancer. So I think in this afternoon, I want to just touch upon some robotics surgery in cancer and what is the revolution and what is the revolutions in prostate cancer. So I will give you overviews of the timelines of current applications, diagnostics and therapeutics, and urology, prostate cancer, and kidney cancer, and other applications, and what is the futures of robotic surgery. I think in terms of surgery, I think that you probably have noticed that in the last few decades and things like that, there's revolutions in surgery. I think in the 100 years ago, I think many do open surgery. With the introductions of antibiotics, antiseptic surgery, all these have changed the surgery field. And in the 60s onwards, we start to see the emergence of laparoscopy, minimally invasive surgery. And in the late 90s, then we start to see the emergence of robotic surgery. And then in the 2000s onward, we will see some natural orifice, transluminous endoscopic surgery. So in the last 30 years or so, I think robotic surgery become more common since the first operative device was introduced back in 1985. If you look at the timelines on the slide itself, I think one of the first robotics application was using Puma's 560s for robots to do a brain biopsy under the CT guidance. And subsequently, we also use bots to do a prostate surgery for benign cases, and even we have robot dogs to do the hip replacement. But not until about 1996 or 97, the introductions of the new robots by Intuitive, I think Da Vinci, that become very commercially successful machine. I think the robotic surgery, I think, is different from the conventional laparoscopy as in general surgery, which is different is that the surgeon can sit comfortably on the console and operate the robotic arm from the control panels. And if you look at the slides itself, I think the robotic surgeries using the Da Vinci platforms, I think the surgeon can sit on the console and look through the console. You can have a 3D camera, very good depth perceptions, and the wrist can be controlled using the surgeon hand and can mimic the surgeon hand, but the advantage is that it can even do 360 degree. So compared to the open and laparoscopic surgery, I think robotic surgery do have a certain advantages. The robotic arm have a 7 degrees of freedom. There's no tremor when the surgeon operates. There's motion scaling, 1 to 2, 1 to 3, and there's also options of doing telesurgery. And the 3D visualizations help the surgeons do better as compared to a conventional 2D laparoscopy. But there are some disadvantages of robotic surgery at this point in time. Cost is the issue. There are some learning curve. The surgeon need to train, and also there's lack of touch feedback and things like that. But this, I think, there are certain improvement progress that to make touch available to the surgeon in future. So one of the things that as a surgeon, I think that robotic platform has made the things easier for other surgeons doing laparoscopy. I think it's just like an automatic car. It's easier to drive compared to the manual car. So more people can drive. Same thing as more surgeons can use a robotic platforms to do minimally invasive surgery. And also, because you can sit on a console, operate on patients at a prolonged hours, I think this can help us to extend our surgeon life, especially for us in the this part of our career. I think the objective of the cancer surgery, I think, is important to have a good cancer clearance, good oncology outcome. Whenever possible, we try to preserve the organs and preserve the function, and more importantly for patients that they can have a faster recovery back to their own life. So robotic surgery do provide these advantages: smaller scar, less pain, less blood loss, and quicker return to the normal activities. There are certain rules of robotic surgery in cancer. 1, diagnosis. 2, tumor removal, organ preservation, and reconstruction. First, I would like to touch upon the diagnostic roles. I would like to use prostate cancer as an example. If the patients with an elevated PSA came in with an abnormal MRI, conventionally we'll do a transfractus, non-targeted systematic biopsy, but as illustrated in this diagram, we can miss a lesion on the prostate. So with the introductions of MRIs, ultrasound fusion targeted biopsy using the robots, this has eliminated or minimized the risk of missing significant cancer. So what we do during the MRI ultrasound fusion is that we use the MRI pictures and combine with the intra-op real-time ultrasound, and we combine the two images together and fuse it, like in this picture. And we can do a targeted biopsy using the fusion's image. Okay. In addition, we also can do a systematic biopsy. So this is one of the robots that are being developed actually in Singapore, initially in the Singapore General Hospital by Robot Monisa. We use robots to positions, automatic positions. So we put in the transfractal probes, and then we can do a transperineal biopsy as compared to the conventional transfractal biopsy and minimize the risk of infection. And we have a fusion software and do elastic fusions, and then we just can do the biopsy just through 2 puncture points. And in this cartoon, you can see that the region of interest can be biopsied accurately using the robotics localization arm. So for tumor removal, I would like to use a prostate cancer example. Most of the localized prostate cancer now, other than being treated by radiation, can be treated with surgery. I think nowadays, majority of surgeons locally, are using Da Vinci robots to remove the prostates.
Remarkably clear, three-dimensional
I think with the robots, with the 3D, with a better image, so we can do a nerve sparing radical prostatectomy. Preserving the better nerve supplies to the patient. They have a better functional outcome in terms of erectile erections preservation and also continence.
Spare these very delicate structures, utilizing the articulating Da Vinci instruments and a highly magnified 3D view of
so
the
basically,
anatomy
like in these
provided by the
illustrations, that we do a nerve sparings,
This added
and we
control
remove
and
the
precision
prostates,
may
and
assist
then
the
we join
surgeon
together.
in preserving the anatomy necessary for urinary continence, as well as the nerve bundles responsible for erections. Once the prostate is cleanly detached, the prostate is then removed through a small incision. The bladder is reattached to the urine channel over a catheter.
So we do anastomosis and
This
over the
catheter is
catheter.
left in place for a short period of time to ensure proper healing.
As compared to the open surgery, I think robotic surgery has
surgery
made
is
this
completed with the
anastomosis much
removal of the
easier.
instruments
So
and
the
the closure
wounds
of
are
the
quite
small
small,
incisions in the abdomen.
and the patient can recover faster.
Prior
So I think systematic review and meta-analysis have confirmed that he has a better overall outcome as compared to traditional opens or laparoscopic surgery in terms of blood loss and transfusion rate. And with nerve sparings, I think the erectile functions is better preserved and also less urinary incontinence. So in terms of oncology outcomes, I think studies have shown that the 10-year outcome cancer survivors is comparable to open surgery. I think robotics surgery for prostate cancer is here to stay. So organ preservation is another indication for robotic surgery. We use kidney cancer as an illustration. With the robots, we can do a keyhole operation. In this case, a cartoon will show that a tumor in the mid-pole that can be resected. we mark out the tumors, and subsequently we clamp the vessels. Then we excise the tumors. I think one of the advantage of robotic surgery in this case is that because the risk of the robotic things that can be manipulated, so that it make the excisions much easier, and also for reconstructions, I think the suturing is much easier as compared to the conventional laparoscopy. So like what I mentioned earlier on is that with the robotic platform, more surgeons can do a partial nephrectomy as compared to a conventional laparoscopy, which is technically more challenging. So robotics surgery have allowed us to do a more complex tumors. I think we can do a higher tumor, bigger tumors, and with a lower surgical morbidity and better preservations of function. So another advantage of robotic surgery will be an area that is difficult to access, like back to the mouth, throat, the voice box, tongues. The conventional instruments is difficult to access there, even with human hands. So one of the things that that robotic surgery can be used in selected head and neck cancer, hypopharynx cancer, oropharyngeal cancer, base of tongue, and tonsil. We can use a transoral robotic surgery. In this case, you can see that there's a tumor at the base of the tongue, and then with a robotic surgery, we can excise it. I think in the conventional open surgery, I think it's not easy to access this area. And then for the patient, I think the advantage of it also less of cosmesis deformity. So robots, I think traditionally use multi-ports, but with the introductions of a new robotic machine with a single port surgery can be done. Although this is not available currently in Singapore yet, but they are available around the regions in Hong Kong and in the US. So you can see that with a single port, you can put multiple instruments, and the surgeon can control the cameras and the instruments to excise it. So I think this is something that we have to look into it to minimize even the morbidity to the patients. So these are examples of the single ports prostatectomy for prostate cancer. So you just go through umbilicus and can remove the prostate. This is an example of the partial nephrectomy using the single ports robotic platform. So there are many other applications that can be used in ENT, pediatrics, neurosurgery, and there are many more applications that we can explore in the future. So looking at the scenario, I think in Southeast Asia, there are many robots that are being installed. For the Da Vinci robot, Singapore has 10, while our competitor up north in Thailand, they have 12. I think this is something we have to bear in mind, the competition around the region. In Singapore, what are the urology cases that we use robot? Majority of them was prostatectomy, followed by partial nephrectomy. We also use it for cystectomy, adrenectomy, and nephrectomy, although this indication is a bit less. And then how about other disciplines? Majority are still used by urology in Singapore, but followed by general surgery and gynecology. But worldwide, if you look at it, other than gynecology and urologists, I think more and more general surgeons are using robots to do this operation. So when you look at the markets, this is the multi-millions markets. And then if you look at it, more than 6,700 Da Vinci machine has been deployed worldwide. And to date, more than 10 million procedures has been done using this machine. So you look at it, it's that by 2025, the market is probably reaching about 7 billion. So definitely, I think surgery has come in a long way from freehand surgery minimally invasive surgery, robotic surgery, and going forwards, I think probably is automatic robotic surgery. Even you look at the Da Vinci robots, they have evolved over the years. There's network connectivities, better visions, and better simulations, and advanced visions, and then the data analysis. So with the robots, I think one of the advantages is that you can use it to do it remote surgery. Technically, we can sit here in this room and operate across the world to the UK. I think it all depends on the internet connection and things like that. Of course, there are also ethical issue, legal issue, who is going to be responsible, the surgeon who operate on the robots remotely or the assistant at the operating theatre at the point in time. But this is something that is come. So there are newer robots coming in the markets. Hopefully they can drive the cost down. This is a Titan Medicals. I mean, it just looks like a computer chair, computer games. I think my son will be a better surgeon than I do in the future. And newer robots like CMS, you can use 3D glasses and open platform, and then you can just do the operation. There are many other modular robots are coming to the markets. Hopefully, we have a better choice. So if we look at in the past, we only had a patient, we use simple instruments to do the operation, and then currently we can operate with robots, with certain device, but in the future, with the artificial intelligence, augmented reality, I think we can do the operation even better. But I have to emphasize that robots are just new tools to allow us to do things faster, more accurately, and more safely. The robots provide us a 3D image, but 3D does not mean that we are better surgeons. So you give me a Ferrari, does not mean that I'm a better driver. I think it's important to know that the tools matters, but the surgeons matter most. I think it's very important to have a good surgical experience and good surgical techniques. And in conclusion, I also have to emphasize that robot is just one thing, but the principles of cancer surgery remain. I think as a surgeon, we have to do multidisciplinary consult to ensure good cancer clearance, good oncology outcome, and preserve the function if possible, try to preserve the organ, and finally, I think good recovery for the patient. Thank you.
Thank you very much, Dr. Tan. Look forward to hearing from you for our panel later on.
Thank you.
Now, you may submit your questions for Dr. Tan via the Q&A bar below the video stream. Next up, we have Dr. Lee Kuo An, a radiation oncologist who has more than 15 years of experience in the field. He currently practices at Mount Elizabeth Novena Hospital and specializes in the treatment of cancers with radiotherapy. As Dr. Chow mentioned in the opening welcome, Dr. Lee will be sharing about proton therapy, accelerating into the future with radiotherapy.
Good afternoon. I'm Dr. Lee Kuo An. I'm a radiation oncologist at the Mount Elizabeth Novena Hospital. Today, I'd like to talk about proton therapy. You might have heard about this, or you might not. So this will be a simple introductory talk. Proton therapy is coming to Singapore. So what is it? Today, we will cover what proton therapy is, what are the benefits, where we might use it, how it's done, and some caveats. So what is proton therapy? Is it like a proton pack at the Ghostbusters? It's actually a type of radiotherapy, and where it has certain physical benefits compared to normal X-ray based radiotherapy, and we will talk about that now. So X-ray based radiotherapy is about 100 years old and has come a long way with many improvements over the years in how we can better deliver the radiation to the tumor by shaping the beam better using IMRT and looking at the tumor so that we can deliver the radiation to the right spot using CT scans. And we can then increase the dose to the tumor using stereotactic body radiotherapy. But the pace of improvements in radiotherapy have been slowing, and we might be starting to approach a plateau. So what can we do to improve better radiation delivery again? and proton therapy might be one of those ways. The difference between X-rays and proton therapy is shown on this slide. First, look at the graph in orange. That's the dose profile of normal X-rays as it enters the body. The strongest X-ray dose is at the entrance, and as it passes through the body, it loses energy, and by the time it gets to the tumor at depth, it's already lost about a third or half of its energy. In addition, you notice that the X-ray continues beyond the tumor, causing radiation injury on the exit side of the tumor as well. Contrast that to the graph in green, which is the profile of a proton. As it enters the body, only a small amount of radiation is deposited. It then deposits all of its energy within the tumor, and on the other side, nothing comes out. And so the benefit is that you have reduced radiation exposure to the normal tissues, both on the way in and on the way out. It is a bit like playing golf. So if you have a particle hit at the correct direction, at the right speed, considering the distance between the source and the target, as well as what it's passing through, you can then get the proton to land in the correct spot. How do you accelerate the proton? This is through a cyclotron. And here's an animation. The proton is separated from the hydrogen atom, and then the protons are accelerated round and round, gaining speed with each round until they exit the machine and is then directed at the patient. This is not unlike a slingshot. The proton is then directed through from the cyclotron room into the gantry where it treats the patient. Within the patient, the proton is directed using pencil beams to treat the tumor spot by spot and layer by layer until it forms a 3D shape of the tumor. This is analogous to how a 3D printer works. What's the difference between proton therapy and the X-rays in the patient? Concentrate on the image on the left. That's a picture of radiation dose using IMRT in a prostate cancer case. In the picture on the right, that's a picture of the radiation dose delivered by proton therapy. If you look at the tumor dose in red, you will notice that the high dose conforms well in both cases to the shape of the tumor. But then look at the color green and blues. That's the low dose and intermediate dose of X-rays versus protons. In the case of X-rays, there's a lot of low dose in the rest of the body, where it says in proton therapy, there is very little dose in the rest of the body. And why is proton therapy becoming more common now? It's technological improvements, reductions in the size, and the cost of proton therapy has increased its availability. Who benefits from proton therapy? Proton therapy would benefit patients who have large and deep tumors, where normal X-rays would expose a lot of normal tissue. Also, young patients, patients who have a long lifetime ahead of them, are susceptible to developing late delayed side effects of radiation, such as second malignancies. And so proton therapy might benefit young patients more. Also, if the tumor is situated in a sensitive organ, such as the liver, proton therapy might be able to deliver the necessary dose of radiation into the liver and yet spare enough normal tissue for adequate function. It's also useful in patients who have tumors that need higher doses than normal, like radio-resistant tumors, chordomas and chondrosarcomas, for instance. And also for patients with need for re-irradiation of previous radiation so that we can avoid further damage to normal tissues. So here are some example sites. In pediatrics, it's useful in brain tumors, rhabdomyosarcomas, tumors in the brain such as craniopharyngiomas, lymphomas, and Wilms tumor. So take, for instance, the picture on the left. That's an example of radiotherapy for medulloblastoma, where we have to treat the entire cranial spinal axis from the brain down to the spine. On figure A, that's an example of X-ray based craniospinal radiation, where you notice that in greens and blue doses, which are again the low and intermediate doses, there's exposure in the heart, lungs, and reproductive organs. Whereas in figure B, the proton therapy is able to avoid radiation of these other normal organs. And several studies have already shown the various benefits of protons in children, having less effect on the IQ, less effect on hormones, and also reduce radiation-induced malignancies down the road. In adults, proton therapy can be used in the CNS. For instance, in chordomas and chondrosarcomas of the base of skull, high doses are needed, and yet we need to spare sensitive organs such as the brainstem. It is also useful in gliomas of low grade, where patients are expected to live many years, and we want to prevent radiation from causing cognitive side effects down the road. In head and neck cancers, proton therapy has already been shown to reduce acute and late side effects such as dry mouth, feeding tube, and hospitalizations, as well as late side effects of dry mouth and hence poor dentition. Going down to the chest, proton therapy is useful for esophageal cancer, where we are treating the esophagus and yet needing to spare the heart and lungs. So studies have shown that proton therapy can reduce both toxicity as well as post-operative complication rate. In the liver, X-rays have traditionally not been used very much for liver cancers because the liver is a sensitive organ. With proton therapy, we will now be able to deliver high enough doses and yet spare enough normal liver function. So this is an example of a trial which showed that with proton therapy, the worsening of the child's Pew score was reduced in proton therapy compared to X-ray based radiation. Again, the location of the tumor makes a difference. Proton therapy would be biggest benefit in deep tumors and large tumors. This is an example of a trial not randomized of proton therapy used in HCC. Look at the bottom of the graph. You can see that local control is very high in the 90-95% range with very good survival. And you can then compare that to the traditional treatment using surgery and local ablative therapies, which also have similar local control and survival rates. Here's an example of radiotherapy, or proton therapy, should say, used in breast cancer radiotherapy. So sometimes it's hard to deliver the radiation without exposing too much heart and lungs. Because proton therapy is able to shape the beam better and stop, we are able to spare more heart and lung in difficult situations. In prostate cancer, especially if we are planning to treat the entire lymph node chain, proton therapy should be able to reduce the exposure of the bone marrow, the rectum, the bladder, and the intestines. Here's an interesting case that I saw. This was a case of proton therapy used in anal cancer. And this patient who had a renal transplant for renal failure, and we needed to treat the lymph nodes without damaging the one and only kidney he had. So what is the evidence for proton therapy? Currently, there's not very much evidence in terms of randomized trials, but they are in progress from head to toe. And here are some examples. But until the results come out, do we really need to wait for randomized evidence before we are able to offer proton therapy? I would argue that's not always the case. When we went from 3D radiotherapy to IMRT, there were no randomized trials, and yet IMRT was embraced in a big way around the world because of the obvious benefits on dosimetric studies seen on the computer screen in reducing the amount of normal tissues receiving radiation dose. Furthermore, we will not always be able to randomize patients in randomized trials, for instance, for rare tumors, and sometimes when it's unethical, so in young children, for instance, where the expected benefits of proton therapy are so great, you will never have the equipoise to randomize a trial. And then finally, one might say, is all this argument for randomized trials because of cost and availability? If you look at the computer screen, seeing how much lower dose that the proton therapy delivers to normal tissue, would you not choose proton therapy? So how do we select patients in the absence of randomized trials? In Singapore, we will likely be deferring to the Ministry of Health guidelines. And in other countries, they have other systems, such as the Dutch, using comparative plans between X-rays and protons. But as a rule of thumb, if you just follow that this tumor is large or deep, or in a young patient, or needs very high dose next to sensitive organs, then quite likely proton therapy would be beneficial in such a case. The procedure of doing proton therapy is quite similar between that and X-rays. We will start with simulation, where a CT scan is done in the treatment position, but there are certain pointers that we have to take more note of in proton therapy. And when it comes to computer planning, there are also certain principles that we will have to follow or pay more attention to in proton therapy. When it comes to treatment, patient will be lying on the couch, and the proton machine will make a round around the patient to acquire CT scan and X-ray for accurate positioning, followed by the treatment. And this may typically take between 10 minutes to half an hour. There are some caveats to proton therapy. So one is that proton therapy does not reduce the dose to normal organs that are within the target. So for instance, if this tumor is surrounding a carotid artery in the case of re-irradiation, we would not be able to expect that proton is able to spare the carotid artery from high dose. Yeah. And there are some disadvantages to proton therapy. One is that the proton high dose may take a few more millimeters to fall off to a low dose compared to X-rays. So the low doses are certainly in benefit of proton therapy, but the high dose X-rays may have some advantage. And then, although it's clear that the proton therapy has lesser intermediate and low dose splash, we still have to prove with clinical trials that these low doses will translate to a benefit, for instance, in lower future second malignancy risk. So one of the difficulties with proton therapy compared to X-rays is that we not only have to point the radiation in the correct direction, but we have to shoot it at the correct speed, or else it will overshoot or undershoot. In addition, there are also biological differences in the effect of protons versus X-rays. And we have to take mitigating measures to make sure that the dose that we intend ends up in the correct organ. So in conclusion, the big advantage for proton therapy is that it stops and hence reduces radiation dose to surrounding tissues. In most cases, X-ray therapy will still be the mainstay and does a good job. So who is proton therapy for? It will be most beneficial for large tumors, tumors that are located in deep organs, for young patients who are still growing or have a long lifetime ahead, who may then be exposed to second malignancy risk, tumors that are located in sensitive organs like the liver, or when you need high doses in a tumor near a normal organ. We don't have much level 1 evidence, but they are coming. Protons have certain physical characteristics that make them sensitive to changes and hence we have to take mitigating measures to make sure they end in the right spot. And there have been many technological advances in proton therapy that have come in the last few years and will be coming soon. In Part Hwee, we will be having IBA Proteus 1 proton machine, which is one of the single-room modern proton machines. All our doctors, physicists, and therapists have undergone overseas training in proton therapy. Patients will first be presented at the proton tumor board for confirmation of their suitability for proton therapy. And we will be following ministry guidelines, some of which are shown on the list here. And last of all, there may be a question of cost. Costs will be controlled and not too much higher than normal radiotherapy. So thank you very much.
Thank you very much, Dr. Lee, for your talk. Our speakers are getting ready for our last panel discussion for today. Do continue to put your questions in via the Q&A function at the bottom of your screen. So for referrals for your patients to see Mount Elizabeth Hospital specialists within 1 day, do use this hotline or WhatsApp. We've now come to the live Q&A of our second session. At this point, we'd like to welcome back Dr. Yong, medical oncologist, to moderate our Q&A session with our speakers from this session, Dr. Yip, Dr. Tan, and Dr. Lee. Over to you, Dr. Lim.
Thank you very much. Yeah, maybe I'll start well with the first question to Dr. Yip. Yeah, because I mean, as a GI oncologist myself, I see a lot of pancreatic cholangiocarcinoma with obstructive jaundice. And I distinctly remember a patient whereby, he's 82 and a metastat was put in for obstructive jaundice. He happened to be quite responsive to treatment, and he lived for 4 years. In the last 2 years, he has to struggle with a lot of stent-related, kind of infection, cholangiocarcinoma, and ultimately actually passes on from infection. So I'm very interested that you had this covered stent versus uncovered metastents versus plastic stent. Can you just tell us a little bit about how you decide which one to put in now?
So I think the first step is to decide whether you want to put in a plastic or a metal. So if the life expectancy is 6 months or more, you would tend to put in a metal stent because it lasts at least 6 months, usually 8 to 12 we tell the patients. And for plastic stents, be less than 6 months, between 2 to 5 on average. And between covered and uncovered, there's not, for metal stents, covered and covered, not too much evidence to differentiate the two. But to say that for the uncovered, there's a risk of a tumor ingrowth and obstructs the stent. And for the fully covered, then the risk is that of migration. Yeah, so you have to weigh the two.
So let's say if you put in a covered stent, would you change out the stent every 12 months? Since that it is removable? Or how removable are those stents?
A fully covered stent is fully removable. And we ought to consider changing them. But these are palliative stents. So usually the patients, unless the life expectancy is unexpectedly long, then yes, we do offer a change at 9 to 12 months.
Okay. Dr. Tan, for prostate cancer, I remember when I was training that you used to say that if your tumor is confined, organ confined, then it's a good candidate for surgery. And then if it's a tumor that is with some extracapsular spread and due to the fear of potential positive margins, that might be a situation that we might start to consider radiation. Does the robotic surgery make any difference to the types of or the stage of tumor that you can operate? And also secondly, for the lymph node sampling, does the robotic surgery make it easier?
Okay, so I think there are two parts of the questions. I think for localized prostate cancer and those cancer with extracapsular extension, I think you are right to say that I think very early cancer, I think we do offer surgery. And then in those days that a patient will have prostate cancer with extracapsular spread or sent to the radiations oncology because those are difficult to do, and then the outcome are not so good. So the lousy cases we send to the radiology, radiotherapists, then surgeon got a better outcome. But those are in the open surgery. I think with the robotic surgery, I think they make things easier to do. You can do a better, even if a high-risk prostate cancer with extracapsular spread extension. I think robotic surgery do offer better outcome as compared to traditional open operation, because one of the things is that blood loss, intraoperative blood loss. In the open surgery, I think there are significant blood in the operating field. So sometimes you really can't see so well. So it makes the surgery a bit more difficult. But I think the important thing for us is that we counsel the patients. I think about informed consent. I think there are options of doing surgery or doing radiations or plus or minus hormonal therapy. I think it's important to tell the patients.
Okay, maybe I'll ask the next question to both Dr. Tan and Dr. Lee. It's about patient selection. So now we have two modalities that we can select for a patient with locally advanced prostate cancer. Can you tell us about the pros and cons of choosing with either robotic surgery versus proton therapy? Maybe we start with Dr. Tan first.
So if let's say a locally advanced cancer, so if let's say it's a T4 disease, I think we don't operate. No, I mean, we straight away will say that we counsel the patient, this is not really a good candidate for operation. We send them for radiation oncologist for opinion. Okay, but for those patients who are just like T3, meaning that they are T3A or T3B, that means that extracapsular spreads or seminal vesicles, if you think that the patient is fit, operable, we give them the option of two. So in my clinic, usually I just tell them the both options and I write a formal letter for them to see the radiation oncologist to say that both options are okay, that you can see, and which one that fit you. I think it's important to let them choose.
Yeah. Dr. Lee?
So Dr. Tan's correct, and there's no definite answer about whether one is preferable to the other. A lot of it boils down to the type of side effect profile that the patient is prepared to accept. So whereas surgery may have a higher incidence, for instance, of urinary incontinence and possibly early impotence, radiation has a higher incidence of rectal bleeding and increased bladder frequency, at least initially. So there are some differences in side effect profile. In terms of efficacy, hard to compare because there's been a lack of randomized evidence. And as Dr. Tan mentioned just now, there tended to be a selection bias in favor of surgery where maybe better, fitter patients were going that way. That could partly explain the better results of surgical series. There is one randomized trial of very early stage prostate cancer that had 3 arms. There was an active surveillance arm, a radiotherapy arm, and a surgery arm. And in that trial, there was no difference in survival between the 3. However, there was a slight improvement in biochemical cancer control with surgery. So that may be some advantage to surgery in that respect. I think at the end of the day, it will be a discussion between the surgeon, the radiation oncologist, and the patient.
I think one of the patients also factors is that I have come across patients that have prostate cancer, different profile. One patient is telling me that, oh, I'm now retired. I have a lot of times. I come to radiation 6 weeks to 7 weeks. Time is not essence. A patient who come and see me is a businessman. He said, I cannot afford to stay in Singapore for 6 to 7 weeks for the treatment. I want surgery, 1 week, I'm out. I can just go back to my career and things like that. So I think there are many factors that we have to factor in.
Yeah, but just to probably add on to that a little bit is that in recent years, the radiation therapy duration for prostate cancer has been getting shorter. So it's true that we used to give about 2 months of radiation on a daily basis but that shortened to 4 weeks or a month with 3 big randomized trials showing equivalence. And more recently, extreme hypofractionation, which is giving high doses in a short period of time, have been able to shorten radiation to 5 days. So I would say that for at least for early and intermediate risk prostate cancer and even some of the advanced stage prostate cancer, we are able to do the treatment in about a week or two these days. Yeah.
Okay, thank you, Dr. Lee. Maybe another question about the proton therapy. Since proton therapy is coming to us in February, can you tell us about how patients can avail of proton therapy? Can somebody come into the GP clinic and say that, oh, I heard of this proton therapy and I really want to see Dr. Lee for the proton therapy? Can they just come in and see you and get proton therapy?
Yes, so I think that's a good thing. So patient will probably be asked to make a referral to speak to one of the radiation oncologists first, and then we will assess the patient case by case and to see, number one, whether radiotherapy is the correct treatment in the first place. Then secondly, is radiotherapy expected or proton therapy be expected to have a superior either efficacy or reduced side effects compared to normal radiotherapy? And if we think that's the case, we will then put the patient up for discussion with a team of doctors in a tumor board, where the doctors will then perhaps sometimes look at the comparison plan of the X-rays versus the protons and see where the dose is going. Is it really going to be superior? And also, of course, it must fulfill Ministry of Health Singapore guidelines on whether this condition is allowed to be treated on proton therapy. And then also the cost is a bit more. And so sometimes patients are self-paying or the insurance may be covered, in which case then all these factors, if everything is aligned, then patients should be able to undergo proton therapy.
Okay, maybe the next question direct to Dr. Yip. With regards to the celiac plexus ablation, when would you choose to do it versus, let's say, generic pain medication, increasing opioids, therapy and all?
Usually these referrals are from the medical oncologists themselves. So after they've failed, maximal opioid therapy, and then they refer to us. We don't get that many referrals, and I must say the evidence for CPN or neurolysis is not that good. Efficacy I showed in the slide, probably 50 to 80%. You can't do it too often, so we don't get too many referrals. Yeah.
Okay. Now, the last question, I will again direct to Dr. Yip. Medical oncologists are getting very demanding over the past 5 to 10 years. When I was starting out in the 90s, nobody cared. Just give me some cells and pancreatic cancer, send home, and enjoy the time next to the sea. So now we want genomic testing, we want all sort of things, want a proper diagnosis and all that. So can you expand a little bit on the recent advancement in FNA versus FNB, which is a core biopsy? And can you get enough tissue for us to do the next-gen sequencing for whole genome sequencing?
I think certainly, because FNB, as the name suggests, you're getting a core tissue, whereas FNA, you're aspirate, you're getting cells. I think with tissue, as you can get many passes. The more passes you get, the more tissue you get. And certainly, I think we can satisfy even the most demanding oncologists nowadays.
Does that increase the risk of, let's say, pancreatitis or infection? And yeah.
No, not really. Yeah, infection definitely not, because these are solid tumors. It's not cysts, so there's hardly any risk of infection. Pancreatitis is shown to be the same as the FNA needles. So I think FNB is definitely the way to go.
Okay. So I think we come to the end of the session. So I will close this Q&A and pass it back to the MC.
Thank you very much, doctors, for that valuable and very fruitful discussion. Also, a big thank you to our speakers, Dr. Richard Quek, Dr. Xian, Dr. Jason Yap, Dr. Benjamin Yip, Dr. Tan Ye Hong, Dr. Lee Kuo An, and our moderator, Dr. Lim Hwee Yong. Not forgetting the organizing committee, we want to thank Dr. Richard Fan and Dr. Chia, Dr. John Chia, CME Chairman of Mount Elizabeth Hospitals. We've also got Dr. Chow, Dr. Peter Chow, and Mr. Yong Yi Ming, CEOs of Mount Elizabeth Hospitals, as well as the facilities management, hospital operations, medical affairs, and marketing team for making this event possible. Now, with that, ladies and gentlemen, we've come to the end of the Mount Elizabeth Hospital's Annual Medical Seminar 2022. We'd appreciate it if you could complete a feedback form for us. This really helps us with the post-event survey by scanning the QR code on your screens right now. We hope you found this event engaging and insightful as we come together to navigate new hopes and possibilities together. With that, thank you so much for your time, and we look forward to seeing you at the next Mount Elizabeth Hospital's Annual Medical Seminar. We'll see you soon.